You got the light flash.
The most important that we answer the question of the parents, and the most important, first of all, in any case, I can cut after that the Zoom. So I propose that you just present yourself, Nancy and Amy, and you told about your experience about the SPML and all, how many children you already treated after SPML and so on. And then we go through the questions. What do you think?
Okay, that sounds good.
Good. So Nancy, if you want to start.
Hi, I'm Nancy Neiditz. I'm a pediatric physical therapist, Feldenkrais practitioner, and a Not-Banyel method for children practitioner for the last 34 years. I met Dr. Jordan and Dr. Nuzzo in 2001 and started to send children to have SPML right then and there when I found out that there could be such incredible changes for children who have any kind of CP, whether it's very mild or whether it's very severe. And I've been working with them since then. And I've seen hundreds and hundreds of children after SPML as a result.
Did you see any negative result from SPML in all your?
No, it's right afterwards. The children can be quite uncomfortable for a few days. There was one family who the child was a walker. He had very contracted knees, so it was rather mild, and they came to New York from very far away to do the procedure, and he wouldn't get up for 10 days. And the father was furious at the mother because he thought that he was destroyed. And instead, he finally got up, and now he walks perfectly. So that's the worst that happens. And there was a 15-month-old that I went to see Dr. Nuzzo with many years ago, and he said, the parent asked, what's the worst thing that could happen? And Dr. Nuzzo said the light could fall on his head during the procedure. That's it. It's so mild.
And Amy?
Yes, so thank you so much. Hello, everyone. Hi, I'm Amy Celento, and I am an Not-Banyel method neuromovement practitioner in northern New Jersey, so about half an hour from Dr. Nuzzo's office. And I have been seeing children, doing ABM with them since 2016. And post SPML, I've seen about 25 kids, which compared to Nancy's hundreds of kids doesn't sound like a lot. However, with the kids, had amazing experiences with post SPML and returning to walking or beginning to walk. And I work very closely with Nancy, so we collaborate so that the child gets sort of all directions of ABM, because it's always great to work with more than one practitioner. And then Nancy's expertise in the world of physical therapy and also working directly with the doctors is it's immeasurable. And so we work together.
Thank you. So can you first, for example, it was my question, in fact, about if you can explain me ABM. Honestly, I never did ABM for my child, so I don't know what is it. I did Feldenkrais a little bit for Mark, so I think it's alike a little bit. It's the same basis, but can you explain me a little bit what is about? In any case, what your method, what you use for rehabilitation?
I'm going to let Amy answer this mostly, but what I want to say about Feldenkrais and a Not-Banyel method is that Moshe Feldenkrais, the method of Feldenkrais is called Feldenkrais method. Anat was his protege, a much younger woman who took most of the children to see, starting in the 1970s, I believe. And she was with him for about 10 years, and he taught her, I guess, most of what he knew. And then she became a Feldenkrais trainer. And then about 20 years ago, the name was changed, and she created her own method spin-off of Feldenkrais called the Not-Banyel method. And so I'll let Amy finish up with that, but it's the same basis of work. It's the same body of work.
Yes, okay. So thanks, Nancy. That's such a great history. So what Not-Banyel did was really look at how is it that children are being engaged to learn? How are they learning new things through movement? And she expanded the work and evolved it by developing these 9 essentials, which every parent can follow at home, which practitioners are using the entire time they're working with the children.
It was the list you were showing, 9 essentials.
Exactly. Yeah, I'll show you. We realized the light has a glare. So everybody can use these 9 essentials, and they've been described by Michael Merzenich, who's the father of neuroplasticity. They've been described as sort of activating the brain for new neural pathways through this method of neuromovement, this Anat-Ben-Yael method. And that is one of the things that differentiates Anat's method from Feldenkrais. There is this deep focus on working with children, which again, Nancy mentioned. Anat started working in the 70s, and she really spent decades working almost exclusively with children, as well as high performers. So you start to see what's happening with the child. When a child has a contraction or a spasticity or a dystonia, they have to organize themselves in so many different ways that are amazing to watch how their brain is figuring things out. So when Dr. Nuzzo, Dr. Rieger, Dr. Ingve, Dr. Price, Dr. Bernius, Dr. Kanalopoulos, if I say that right, what they're doing is, allowing for that brain-body connection to be established more clearly, a little more hand in glove. And then we come in with this neuromovement to really help that reorganization or more efficient organization start to happen within a child's movement, and also with their thinking. So you start to see it with their thinking, with their cognition, their learning. And I guess the other thing I want to say is that in the previous meeting that we had with Dr. Nuzzo and Dr. Rieger, there was a reference to efficiency of movement, efficiency of energy use.
Yes.
That is one of the key things of this method. We're working to create this organization, this better organization, so the child has a more ease of movement, hopefully a little bit of an enhancement or an improvement.
We have one more. Somebody's coming, parents.
We have somebody
joining.
Yes. So that's really what's happening with neuromovement. The focus is on the child, and I guess we have Polly joining. I just want to say that every parent can find this document, From Fixing to Connecting. It's on Anat's website, and it really just talks a little bit about this focus of connecting with your child to help enhance their brain-body integration. And that's one of the things that often. Uh-oh, we have an echo. Oh, there we go.
We have one parent who's coming, Polly. Yes.
Yes.
Polly.
Yes. So we just had an echo there for a moment.
Yes.
But that's one of the things that, sometimes differs from a physical therapy or an occupational therapy approach. We're not just focused on trying to get a child to do something. We're working with their system to enhance and expand their possibilities and their options. So, it's not a criticism of other methods. It's just an underlying baseline. It's like a wave of connecting with the child, with their brain, with their entire nervous system through movement. So Nancy, I don't know if you want to add something.
Yeah, so a good example of this is every time we move or we do anything in life, we only volitionally do it if we have a connection in our brain. Okay. And for example, when a child goes to reach for a toy as an infant, in the beginning, they can't reach for the toy. It's impossible. So, nor should they be able to as newborns or at 1 month or 2 months. Starting maybe at 3 months, they'll start to reach sideways or a little bit towards the middle. With children who have special needs, they have not been able to do that because of the restrictions in their body and because of the misconnections because of the brain damage. What we do as ABM practitioners is we create the conditions for that to happen easily. And I'll give you a good example. Many years ago, we had a child who had a terrible epilepsy problem and she couldn't do anything. And I saw her and Marcy Lindheimer, the other Anat Banyel method trainer. This was about 24 years ago. And we sent this little girl to go see Anat, and she was doing nothing volitionally. She wasn't rolling, she wasn't grabbing, she wasn't feeding herself. I would say she was a year and a half at this point. So what Anat did was she realized, what did the child want to do the most? And what this child wanted to do was to eat. She loved to eat. So Anat took a bottle and she had the baby touch the bottle. She held the baby in such a way that it was easy to touch the bottle. And every time that she touched the bottle, Anat put the bottle in her mouth. And she did this many times in many different directions, in many different ways, because that's how the brain creates more synapses, by having variations. She did it slowly. That's what Amy was talking about, the 9 essentials. And she did it easily. And that's the key, is that you make the movement so simple that it becomes an inevitable action. And so what we do is, no matter how difficult or no matter how simple the task is that we're asking the baby to do, that for most of us, we think, how could they not be able to do that? Well, we understand that they can't. We make it so simple that they do it. In other words, and that was Moshe's one of his main staples, was create the conditions to have the person be able to do the activity.
Do the activity.
Actively do it. Now you've created a synapse. And that's the synaptic, that's what's happening on a cellular level. So it's not about taking the child's hand and putting it on the bottle. It's about supporting the shoulders. It's about getting the rib cage organized. It's about getting the head organized, so that it happens, and then it happens over and over. And it has to happen many times before you create.
To create the novel synapses.
So, and I'll give you an example of what is impossible for us. So when I do my hair and I put a mirror in front of me and a mirror behind me, and I'm trying to see with that mirror my hair behind me, what I see is an image of something behind me.
Behind.
Hard for me to figure out, am I going this way or this way? That's what a child who has never reached for a toy feels. That's exactly what they feel. And that's why we have to realize it. So we have to understand what we can't do. And that's exactly what they cannot do. And so you practice it over and over, but you don't make them so fatigued that they just get so frustrated. So you do it this way, and then you put the arm down, and then you put it a little bit this way, and then you support and so you just keep making it simpler and simpler and simpler until they just do it. And then once they do it, you remind them how to do it. And then they remember, and now they have a connection to do it, so that the next time they can grab something. And that thing that
one more parent who's coming now.
And the thing that the child is going to grab. So whenever I work with a baby, and I'll just show you, I have them grab things that it's inevitable. It's like the finger gets caught, now they have it. Or I use rings, so they're not going to choke on the rings. And it's like, now they have it, their hand goes. And so what happened with this baby that Anat worked with is, by the end of the week, the baby was actually able to grab the bottle and feed herself. And what Anat said was, now she has agency over herself. She knows that something she does in this world gives her something that she wants. And that's what we create for children. We want to create their independence, whatever that is, whether it's reaching for a toy or feeding themselves or rolling or coming up to sit or getting off the table and walking sideways or grabbing their walker and walking. But whatever it is not about making it so difficult that they're struggling in every movement. They can't breathe, they can't move, they're stuck. And that's what a lot of PT does, because physical therapy has its roots in gymnasium from the First World War. It's about getting people out of bed and moving, which is a wonderful thing. So when people are sick now, when you go to the hospital, you don't lie in bed for 10 days, you're up and moving. But they conflate this idea of getting up and moving with people who have brain damage where they can't move. They absolutely can't. And they jump to the next step, and their brain has no connections to do this thing, but they want them to do it. The parents want them to do it. They want to do it. The PT, everybody wants them to do it. I get it. I want them to do it. But you have to go in pieces and you have to break it down. And if you want them to do it well, you start.
For the children's, but for the children's, for example, even for the children's, they may say 1 or 2 who can do it, and it's just a small problems which you have to correct. It's even more easier, must be.
Well, if a child, so if they're a GMS, how do you say it? They're a first CP. The GMFCS level 1, where they're already walking, but they have legs turned in or they're on their toes. First of all, the SPML will kind of undo, help that immediately. And then what we do is we work on the really subtle changes of how do you weight shift. So you don't just get up and have the child now try to balance and weight shift at the same time. You work on the table, you work in lying down, you work on coming up to sit, on feeling the sits bones underneath the pelvis. How does that connect to the bottom of the foot? How does that connect to the legs? And then you slowly bring them up to stand in a way that it's not, they have to hold themselves. Because as soon as you get the child in the place where they're struggling, they're going to go back to their old patterns. Why? Because the most important thing always is not falling on your head. That is why the first 12 months of life, we are down on the ground, because the fissures in the head have not closed yet. And if the child falls, they will crack their head open and there will be a bleed and they will have brain damage. So we are meant not to be up and walking until we can protect ourselves in all sorts of ways. And not to keep talking, but another example of this is when we go skiing. If you are a beginning skier, what you're going to do is you're going to lean back as you go down the hill, because your balance reactions do this. And your teacher
also.
Lean forward. You're never going to lean forward no matter what, ever. It's never going to happen. It's the same. I was talking to Marcy last night. It's the same for singers. If somebody doesn't know very well a song and you ask them to sing loud, they're not going to sing loud, because people don't want to they don't want to feel the shame of doing it wrong. The same as they don't want to fall, and falling is even more primitive. So when we work with children after SPML, they have a different configuration in their body. So now, instead of just going and doing these very big exercises and holding them up by their shins and making them balance themselves, we start slowly. How do you roll? How do you come up to sit? How do you come to stand at the table? How do you cruise sideways? We go really slowly. So they learn a new pattern without stress. And they keep breathing.
Yeah,
Hello, Andrea. Andrea, can you hear us? Hello, we can hear you now. Now you activate your sound. So you're one of the parents who is coming because other parents, they are late. So if you have any questions to Nancy and Army, they are working a lot with the children after SPML. You are welcome to ask the questions.
Perfect. So, Svetlana, I wanted to say that Andrea, she's actually a very experienced and talented practitioner. So thank you, Andrea, for being
okay.
here.
You never learn. It's never too late to learn more. No.
Yes. Yeah. Well, thank you. Thank you.
A lot more. No, I think it's like you have really a lot of SPML clients, whereas I have some in a while. No, I've been working with, but of course not as much. And I'm thinking of since I've been also interested in sending more and more kids to Dr. Kanelopoulos in Greece. I'd like to be an advocate also here in Europe for people that are want to have an first phase intensives after the SPML surgery. That would be great if I would be available and maybe gather a few of us here in Europe who work with children after SPML.
Yeah, thank you.
By the way, it was one of the questions, when it will be the best timing to do the intensive after SPML. It was one of the questions of the parents, you remember?
And exactly. Yeah. So I want to say that it was great. Svetlana sent us this fabulous list of questions. So Nancy and I sort of figured out, how can we
Yeah.
tag team and answer these? And Andrea, of course, we welcome your input. However, I just want to say I don't know how much time you have allotted, Svetlana. So just want to check that out.
No, it's okay. It's okay. We can continue.
Okay.
Just at any case, I wish that you answer the main questions you have on the list, because the parents, they send a lot of questions.
Yeah.
Sometimes it's more related to SPML, sometimes it's less related, but I think the most important question is one of the questions, it was when we have to start intensive
Yes.
of SPML. Second, if it's every time we use the ethanol blocks after with the SPML surgery. And very important questions, as there before, after. It's also
Okay.
very often question asked.
Yeah, so Svetlana, to your point, I'll just jump in on the intensives doing ABM, neuromovement. So typically, if a child is here in New Jersey, they've seen Dr. Nuzzo or now Dr. Rieger, we like to start with them really about 2 days after the surgery. A lot of children, the first day, they're really still, they've had anesthesia, they're maybe feeling some discomfort. We don't usually start right away. However, in some cases, depending on the family's travel schedule, and we might see them and just do some gentle things. That's the beauty of ABM. You can do very gentle work. We're not focused, as Nancy said, just getting someone on their feet. So typically, it's really helpful for a child to be able to stay and have lessons for 5 or 6 days. We call it an intensive. And for some children, they have 2 lessons a day. For some, they have 1 lesson a day. And as I said, for New Jersey area, as well as if they see Dr. Price in New York and they want to come here, Nancy and I just alternate on seeing the kids. I do want to mention that we have fellow practitioners in New York. We have practitioners in Texas. So for Dr. Ingve, Elisa Franklin, she's an assistant trainer of an ABM method. She sees clients after SPML. Andrea, it sounds like you see some in Germany.
Yeah, and in Denmark also.
And in Denmark also, great, yeah. And then Beryl Tokchen in Turkey sees patients, so some that go to Greece, if they go to Turkey after, or if they're actually from Turkey. And I guess I want to say that the beauty here of Nancy's work and all these years of collaborating with the doctors is that Nancy can speak the language to our fellow practitioners. So they can do a consult with Nancy, even if they're far away. The practitioner and the child, they can do a consult with Nancy. And sometimes Nancy's going to bring something in that maybe, somebody else wasn't picking up. So that's why we collaborate within the ABM method. We all collaborate, the practitioners do.
This is great.
So yeah, so if that answers the question, they can start really within a day and a half to 2 days or so.
Yeah.
On having an intensive. And then just on the going farther out, we're always advocating for children to have lessons, because as Nancy said, we're working with them feeling the weight and movement through their skeleton. It's not the idea of just get somebody on their feet. So I don't know if you want to say anything else about that, Nancy.
It's just that, so where my piece fits in a little bit more is that I understand that now, if the child is a level 1, 2, 3, or 4 of CP, we do definitely want to get them on their feet in some fashion, even if it's very difficult for them to be standing, and we want to give them all the support to do that. And the reason for that is we want to get the foot really getting some contact with the floor. All of them give casts to the children. The fingers are free because they balance on the fingers of the toes, and it goes halfway up the shin. And so it's a walking cast. And as soon as the child's able to be standing in that, we want to get them up in that, even if it's pushing through the table and pushing through our chest. We want to get them weight bearing. So for a level 5, we would have them pushing, if we can, to get them to start to connect with the hamstrings and the gluteal muscles, and connecting the foot to the pelvis through the spine. So depending on the child's level, but it is very important to keep length in the knees after the SPML, because they take the hamstring, the gracilis muscle, and they release it so it's not contracted anymore. And you want to keep it long. I normally don't care if kids W-sit, I encourage it, which is very different from PT.
Yeah.
What most PTs say is it's going to screw up your hips, but actually until you're 5 years old, you have a lot of anteversion in the hip. It's normal. If you go to the playground, half the children are W-sitting. Again, they conflate W-sitting with CP. I mean, kids with CP can only W-sit before the procedure, mostly, because they don't have the length in their hamstrings. Now that they're going to have the length, I like to put them in knee immobilizers to sleep. The first few weeks, the doctors want to do that because they don't want them to curl up. They want to keep the length. It's very important after the procedure. They have to keep the casts on for 3 weeks, or they have to wear AFOs that are fitted properly for 3 weeks to keep the mobility. Otherwise, the foot's going to go back into a pointed position. So there are certain things that should be followed in addition to the ABM that we're doing, but those are very specific and they should not be ignored. Even if they look like traditional pushing, there has to be a bit of some of that just to keep the integrity of the muscles at the length that we need.
I see. And then how you can then answer the question? You remember the parents, they asked if you saw already that GMFC level changed after the SPML.
Yeah, of course, because if a child is a level 3 and they're really having difficulty, they're so fatigued in walking with the walker, or they're just scissoring all the time, what this does is now it's quiet and now they're able to put the foot down and not have one leg shooting up every time, so you get this kind of gait. You're not going to have that anymore. It's going to calm down. So I'm going to show you I use parallel bars, and people can make piping. We have I made a list of how to make piping for people. So you want to have parallel bars because they're stable, more stable than a walker. It's easier than a walker. And they can really start to learn to weight shift in that. I have them stand. I also have a bar in my office.
Yeah, I have a bar.
Yes, and I also have a Pilates machine. And the reason that I like the Pilates machine for high level kids, let's say between 3 and 1, is that, or even a child that's quite weak, if they're tall enough, they can start to push away with less resistance than their body weight because you put them on springs. So it becomes a very good tool, the Pilates machine. Not Pilates itself, but using the machine for mobility.
Is it a reframer?
Yes.
Is it a reframer?
It's a reformer.
Yeah, reformer, not reframer. Reformer, yes, yeah.
But it's if you get somebody to make you a pediatric one, that's even better. The one I have is adult size, so I put wedges and stuff. But it's a very, very nice tool, and it's also good for some core strengthening, which we don't usually talk about in ABM, but there is a kind of work that we need to do to get the core strength, to get the back strengthened. So that's kind of, I'm in between the ABM world and the PT world.
Yeah,
okay.
Can
Can you tell us also if there is a special exercises you advise for hemiplegia children, because they have only one part of the body and generally they compensate with the body which works good, and maybe there is a special exercises better for the hemiplegia children, because I have a lot of children, parents of hemiplegia.
Yeah, so it's such a great question, Svetlana, and a lot of what we do in ABM is working with the side that's already highly functional, that's already available. And so we're bringing in the other side, especially if there's just been an SPML. However, a lot of times we're starting with the side that's really available. We're talking to the child's brain and body, and the brain starts to sort it out between the side that's effective and the side that's more available. And that's the beauty and the power of what we do and how we do it, is that we're talking to the whole system, yet we're really tapping into what's already working. You're building on what's already working instead of trying to activate something. And just having had the SPML, again, as long as they're not having severe pain, of course, we start bringing the other side, as Nancy said. Sometimes we'll start with more of the weight passing through while they're on the table, they're lying down, then they come to sitting, and then they come to stand up. And you see very quickly, you know, usually within a couple of days of having had SPML, the brain is already sorting it out. One thing I want to mention is that after the child has the surgery, they might feel tired. They also might feel a rush of energy because now they're not working so hard. Everything isn't having to work so hard. However, they still need a lot of rest. They still need a lot of rest to integrate everything that we're doing with SPML. Doesn't mean they can't go out and have fun. They just need a lot of rest. So Nancy, I don't know if you want to add to that.
Well, if it's hemiplegia, that's actually the easiest thing to work with because one side is already very functional. And one of the things that I always do that I've learned is so constraint therapy sometimes is also important. We've done that, Anat's done that. We try to make the side that's functional kind of go away for a bit and let the child do some simple things with this arm. But even more than that, what we do is we let them do whatever they want with the functional hand while we're working on getting connections between the sternum and the rib, between the clavicles and the ribs, between the neck and the shoulder, because they've never done these things. And so they have no mapping in their brain for this part of the body. And so when you gently do that and you don't force them to do it, all of a sudden it starts to wake up in a different way. And I'll do things like have them put like their favorite candy, soft thing that they can put in their mouth, that only with that hand, so that it becomes a pleasurable hand, or a particular snack with that hand. You have to be careful in terms of choking. I have two rules always. It's no choking and no falling. And the choking is especially. And you have to realize that when you eat something, if you even eat something with your non-dominant hand, when you put that in your mouth, even your mouth is less coordinated. So you have to be very careful if you're going to work. When I work with food with children, I work with crumbs practically. And I don't ever deviate from that, because watching a child start to choke is it's like heart attack time for anybody, and including the parents, everybody. So you have to be very careful with that. But we do introduce using that side in a way that's not noxious, that's not difficult, that's not forceful. You're waking it up and you make it pleasurable. Mm-hmm. And I do things like I use tricycles and bicycles and adaptive equipment. And when I do a tricycle, for example, even with a normally developing child who doesn't know how to pedal, is I always push the tricycle so the child feels this motion. And then you just make it like just do one put, so it just becomes something, and you have to be very patient. And I think that's the key for ABM and Feldenkrais practitioners. What we do learn is how to be very, very patient. And I will say that my experience in 35 years in watching parents with children, especially level 5, is that it's so hard to watch their children not be able to do things, that they would rather do activities on the child that doesn't demand that they respond in some way, because it's too hard, a lack of response. And so I see, and I'm not going to name the other methods because it's not polite and I don't want to diss other people, but there are many other methods that people utilize that are not quite getting to the brain. They're just doing things to the child because it's easier I think for the parent to not have to see that the child really is having difficulty. Again, we try to do it in a way that it really is simpler the next time and the next time. And it's frustrating. I mean, level 5s are difficult. There's no doubt.
Absolutely agree for the parents with the child level 5. It's very difficult. Can you also maybe tell us, as you experience, in which kind of CP it's more difficult to say if it will work for the child, because we have different types?
So I will say that it works it depends on your expectation. So for a level 5, it will help with toileting, with changing diapers, with mobility in putting on clothes. So it will help with activities of daily living, definitely. And it will help with the child's overall freedom, and with weight shifting. And that's why people do it if they have a child. It's not fair. Sometimes on the SPML pages, when we show children before and after, a lot of those children are level 1s who are already walking, and then now they're running. That's not, that should not be the expectation. And I wish it were, but it can't be. So you, at every level, you have to look exactly at what are your, in ABM, we don't talk about goals so much, but there are goals. People aren't coming to us to just play around with their child and just experience things. They have a goal. Everybody has a goal. There's a reason why they're there. So we have goals, but then we make them flexible, and that's part of the 9 essentials.
Good. Just maybe the last question. I think generally we did the majority of them. Who wants to answer the question about SDR? I know it's the question which is very difficult to answer. I'm sorry, but it's the usual question which comes always: SDR before, after, what to expect, and so on. Because we saw a lot of children also on our page who had SDR and after they have SPML and with good results.
Yes. So
will be what you think?
Well, what you have to understand about SDR is it can be very helpful. I personally can only speak about children who I've known who've done SDR in the United States or even in Europe, in Missouri, Dr. Parks. There have been some atrocities that I've seen in Europe from doctors there, and I don't know who the doctors are specifically, but I can only speak to Dr. Parks. He is very specific about the children he accepts. What people have to understand is that immediately after, they do lose a lot of kinesthetic awareness that they have to rebuild again. And I've been to the clinic in Missouri, and the PTs are very nice and very gentle, and it was a nice experience seeing them working, and they're trying to get them strong again because they do lose some strength. In that procedure, they lose strength and they have to rebuild it. But they do, a lot of times they do lose a lot of the spasticity, which is a good thing. Dr. Nuzzo and Dr. Price, I believe, and Dr. Rieger, I think that what they prefer is that somebody do SPML first. And the reason for that is, I've been in the procedure, it's very mild. They're not touching bone, they're not touching muscle, they're not touching tendon, they're touching the fascia and the nerves that run through the fascia. So it's an ocular scalpel, it's a release. It's like watching them do Botox, I suppose, without the poison. And it lasts much longer. So, or the alcohol, both of these things are percutaneous, it's under the skin. You're not delving deep. When you go into joints and bones, this is a whole different ball of wax. There are no incisions, which makes a whole different ball game. So there's so little down. I believe one should try the SPML first and see if that works, and then if that is not enough, but give it time with therapy, then people can always do SDR. But if you do SDR first, it's not that you can't do SPML later, but it's a lot harder to get over the whole surgery. So it depends on the parent, on the doctor, on, and I would have a consult with Rieger or Bernius or Canalopoulos or Price or Nuzzo and see what they say.
Good. Just last maybe question, as I know, I have the documents about the protocol you give for the parents, and you give me permission to share your protocols, and I translated it even to Russian, so the Russian people also can read now the protocols, what you advise for the children's after the SPML. And also I will share both of your sites at the end of our discussion, and then on the site of Nancy, they can find all the contact information of all doctors who is doing SPML.
No, actually, just go to the SPML page today. It's
Yeah.
up. I put it in, all the doctors, all of the orthotists, how to reach them, where they're doing it. Ingve in Texas and Galveston, and Dr. Price in Miami, in New York, with 2 different hospitals in New York, at NYU Langone and at Hospital for Joint Disease. They can accept Medicaid, and you can get waivers from different states to do Medicaid in New York. So if you don't have the funds, you can get it done through Medicaid. And at these hospitals, insurance is accepted, at all different insurances. For Dr. Rieger, Dr. Nuzzo, they will give you super bills that you can give to your insurance company if you have out-of-network benefits.
Good. And also you have information about Canelopoulos and Bernius or not on your page?
But one other thing, in New Jersey, if you don't know this, this is really important. If there's something called the Catastrophic Children's Fund, and if you have a child with a severe disability or any disability, and you have medical bills that exceed 10% of your gross income, then you can get all the money back. And you just have to show them all of your receipts and that you yourself paid for it. But it's a wonderful program.
Oh, thank you very much. It's very, very important advice for the parents. I think they will appreciate this, especially for United States parents. We are in Europe, it's a little bit different.
Svetlana, you had a question about Galileo.
Yes, I had a question about Galileo and hyperbaric also, if you want to answer it.
Yeah,
What can we do Galileo and hyperbaric after SPML? It's parents who ask, because I'm not doing Galileo at all for my child.
You can do Galileo. I don't, and I believe you can. I don't exactly know, but I don't want to say that because I would have the surgeons answer that. I can't imagine it would do anything harmful, but I don't want to say officially because that would be remiss for me too. And also, I want to talk about the medications that they suggest after SPML. Some parents are very natural and they like natural remedies, and that's fine, but you wouldn't do surgery without anesthesia. That's not natural. And when they tell you to take the whatever amount, whatever dose of Valium, it's important to stay ahead of the pain curve. So I can't tell people to take Valium at all. It's not my place. It's not my purview. It's not my part of my work, but I can tell people to definitely follow what the doctor says, because it's for them in a lot of pain.
Absolutely. It also depends from a child. For example, there is children, they don't need Valium, and some they need.
I want to say also that AFOs, I want to speak about that. A lot of people use a hinged AFO, which means that in the back it has a hinge, and they believe that that is more, gives them more mobility, and it's better for them, and it's more comfortable. And Dr. Jordan and I have spoken about this many times. It is not helpful. And the reason that it's not helpful is that if you use the hinged AFO, then what happens is the child uses just the soleus muscle, which is the tiny muscle in the calf. It goes up to here. It's not the gastrocnemius. With the solid ankle AFO, they have to use the gastrocnemius. That's the muscle that gets really tight. And also, if they end up having a hinged AFO, they use their hamstring, the muscle behind the leg, as stability, and they start using the adductors in between the legs to stabilize. What we have to do when we walk is we have to use our gluteal muscles. So we have to use our behind. We have to use those muscles, which is why it's very important. One of the exercises we like to do is have children walk on their knees, and they can't. It can be quite difficult. When you see a child, a toddler start to do this, and people say, oh, they can't walk, I always say they're almost there, because if you can use this to stand up and balance, that's what you need, all of us need to walk. And if you're using your hamstrings, you're not efficient and you're gonna fall over. The reason that they release the gracilis fascia in the gracilis tendon is that now you have movement in the hamstring, and now you can connect up to your gluteus muscle. The AFO will force you, it's like wearing a ski boot, to use the gluteal muscles.
To use these muscles, yeah.
The backside, the buttocks. Those are really important, which is sometimes why I have children walk along a wall, facing the wall, not doing this, because when they do this, they can lean forward. Now they have to stay straight. So one of the things that I do before I allow them to walk forwards is I have them walk on the wall. And can they do that? That's a test to see, and it's hard, and but they have to use those gluteal muscles. So one of the activities can be walking on the knees or walking on the sideways on the walls. But it's very important after the surgery, they do 24 hours a day for 3 or 4 weeks, the mobility in the ankles, and then knee immobilizers at night. But also, now during life, they shouldn't wear it 24 hours, they should wear it 8 hours, especially when they're standing. And then they should be free, because if not, then when they sit, they can't do things like this. They can't sit on their heels and get this kind of, because they're stuck here. And you want them to be able to have this kind of movement, and you want them to be able to shift and get up here and come down here and do this and move all around. That's really important. So you don't keep, and especially when you work with them after SPML, I would say if they just have AFOs on, keep them on for the first few weeks. So when Amy and I are working, we keep them on. I don't want to take the chance of having the child lose that mobility, but then afterwards I always work without the AFO unless they're standing and walking, and then I put it back on.
Okay, I see. But we have some children, for example, like mine, which with the dystonia, it's much more complicated with that. For us, you agree with me?
Athetoid CP, you can't put an AFO on, because now they're going to fall on their face, because they're in constant motion, and they'll trip and go flying if you put an AFO on.
No, some children with dystonia, they can use some offers, but in our case, for example, didn't work. And Dr. Nuzzo, he explained me very well why. Because dystonia will be fighting against at any case. And the last question, because I just made it for 1 hour. I thought it will be 1 hour Zoom. But if you have an examples of the children that you saw, they got second time SPML. So in some cases, we have such kind of thing, like second time SPML. I'm prepared, for example, for my child, because if the child grows, sometimes we need the second one. So can you tell me if it's much more easier the second time, if it's much more quickly, or instead it's more complicated? What your experience?
I've had a lot of kids do it twice because they grew. I don't know why, but all the kids who do SPML get really tall. So, I mean, a lot of kids, no, just kids are, and when they grow, so the bone grows faster than the muscle, and so it pulls. So yeah, and it's, I just have to say that the SPML, people keep talking about, oh, the surgery, should I do the surgery? And it's such a nothing procedure. I mean, it's They can even do the SPML part, not the alcohol blocks. They can do the SPML part almost with just local anesthetic. It's not such a big deal. Again, you're not going in the joint, you're not going in the bone, you're not going in the muscle. That's a whole different thing. You're not cutting tendons and lengthening them. So it's really, people should not be so worried about it. It's really nothing. And I really mean that. I mean, I've seen it. It's like, and there's a video of, if you Google Dr. Nuzzo in The Doctors, it was a TV show about, and they show the procedure. It's there somewhere. I'll try to find it and put it on SPML page.
Good. It'll be nice to see procedure. Yeah. I don't know, maybe you have more questions. I asked a majority about, and that the parents, I'm really, it's a pity that we didn't get other parents. Well, we had one, but she disappeared at once.
Well, I have to say that the weakness, they ask a lot, are you gonna, this is what PTs will tell parents, don't do SPML, your child's not gonna be able to walk afterwards. It's nonsense. I've never seen a child get weak from SPML.
Yes, ever. A lot of other orthopedic doctors also, they are against, because they don't know much about.
How does?
Yeah. Oh, go ahead, Nancy.
Oh, go ahead.
Well, that's why I was going to say where the reorganization of the brain and the body come in. So yes, the child's used to having a spasticity or a contracture and maybe relying on it because they have organized themselves to function to their best ability at that time. And so by doing ABM, we're helping the child reorganize their movement, and all of these little missing pieces of the puzzle start to get filled in. And so this fear of, oh, they're going to lose their strength, it's not an issue. It's about the organization, and the strength comes as you're organized. I mean, that's the easiest, layman's way to say it. Nancy, you might want to add to that.
We get a mapping in the brain differently when we do it. And the piece that they're missing, putting the child and getting them to walk and pushing them. And it looks like walking, but if you really try to get them to not hold on and walk, they're just hanging on with every single ounce. And it depends. I mean, especially for level ones, we really want to get them to the point where they're just walking, where they're just on their feet, where they're not working so hard, which is why parallel bars are nice, because they can immediately have something to hang on to and weight shift. But the more connected you are in your brain to the activity, the better. I'll give you an example. When I was 14, I was trying to play tennis and I missed every single ball. I didn't know what I was doing. And then I started to dance, and I was in dance class, modern dance class, every day. And it's all about weight shifting and moving in space and figuring out where you are. And a year later, I hit every single ball. I mean, I didn't play tennis well, but I was able to shift and move my body. And we are more like dance than we are like just strengthening. That's what I would say, that ABM and Feldenkrais is more of a dance. It's more of getting the body. It's a matter of getting the skeleton to move in all of the ways that it should be moving, to take their place in that movement.
Yeah, Svetlana, I see that Polly, before she went, she said how and what type of exercise is the therapy. So of course, we're not going to show videos here. However, anybody can go on Anat Ben-Yael's channel on YouTube and just see what lessons look like, if that helps. They're not specific to post SPML, but you can see for different conditions that a child might be born with or might have acquired. There are examples, there are videos. And again, those are all done by a practitioner. We're not suggesting that a parent just try to emulate what's happening.
Right. However, I want to just say one thing. I always give parents home activities, always, even the first day. So they have things to do. It depends on the child, though. You can't just say, what activities do I do? It depends on the child, and it depends on what they did and what they can do. So it's very personal.
I see. So you give homework for the parents. Not all parents doing homework. I'm doing a lot of homeworks.
You absolutely are. Thank you.
Yes, I have a really good also PT here in France. We don't have a lot ABM practitioner, but she's doing a lot of other things, and it looks like I don't know if you use such kind of thing in ABM, but it's like archaic integration of archaic movement, something which child normally must born with. And we have a lot such kind of thing in Europe because we don't have much ABM in Europe, you know. And I think it's very, very, very alike, in fact, like a method.
What a lot of people are doing a kind of method where they hold the child or by underneath their feet or by their shins. And the child it's really good exercise for the practitioner, but if the child falls, they're going to crack their head open. And we work from the bottom up. We work on being able to roll, being able to come up to sit by themselves, being able to twist and turn, being able to get on all fours, being able to bring one foot forward. So I'll show you an example of it. When children have CP, this is how they come up to stand. Like this, because and so after SPML, one of the things that we really try to do is to weight shift and bring one foot down and wait, but we don't just force the leg forward, right? Because they don't have this ability quite yet to do this. So we're constantly working on how do you get them to shift? How do you get them to put a foot, to do all of these things? Because eventually we want them to be able to come up like this more easily, to differentiate. And when you have CP and you have cross extension reflex, the legs are shooting up all over the place. You can't. They have to go together. And that's something that gets changed very nicely with SPML.
So the child's movement is really enabled, which is a different experience of.
Maybe Andrea wants to tell something at the end of our meeting. You have any questions for Nancia and Amy?
Yeah, I was going to ask Andrea for you to speak.
Thank you very much for making me listen. It's always inspiring and always like you see it in different lights. And of course, I want to know but a question is that many parents ask, should I only do ABM after the SPML surgery, or should we go ahead and work with our PT, who is then doing, in the best case, is doing Bobat, but in the worst case, they're doing a Voita, which is a very, it's much more limiting and harnessing and pressure. So it's a lot of demand for the child, and I don't see how this could help the child. So for me, that is one of the questions. It's quite individual. I have been handling it very individually, depending very much on the child and on the PT, how gentle they work. So what is your take here, Nancy, Amy, on that? What have you been experiencing?
What I do is I tell, as long as the physical therapist, again, is working gently, isn't forcing them into positions. And what I try to do is collaborate with them and have a meeting with them or have them come and watch what I'm doing. And again, I'm not trying to be a bully and tell people you better do it my way, but if you're going to do this particular method, then let me turn off this. Then it's very important to stick with what you're doing. Now, having said that, I do believe, depending on the level of the child, that it is important to keep them moving and to not just tell the parents, okay, well, I'm the ABM practitioner and this is what just come to my lessons. As much as the child can move, you want to keep them moving. And I just have to say that it's 35 years that I'm seeing children now. And what I will say is that up until now, when you have a child with severe CP, even if they do SDR, even if they do SPML, even if they do whatever they do, it's very hard for them to stand and walk. Walking is a really hard thing to do. And I feel very badly now for children. I feel very bad for children that everybody just keeps saying, you have to walk, you have to walk, you have to walk. I would rather that the child not be walking, but sometimes for transfers or whatever, and that they don't feel bad about not walking, but that they feel good in their lives and that they feel good about whatever ability they do have. And it shouldn't be just all about getting up and depending on the child.
Yeah.
But in terms of strengthening, I think it's important to keep moving, but within their ability to move, so it's not too difficult. So if the person is doing bow bath and they're gently moving them and the child's, then I think it can be fine. I hate to tell people don't work with somebody. It's not my place, but.
Yeah. Okay. Thank you.
Especially that in Europe, we have a lot of other therapies. For example, I'm very happy with my therapist, and I know that she is working with Mark only with the like playing games and so on and so forth. It's always participating from the child. It's very important, and he just loved her. He just okay now Kati, she's coming for 2 hours. It's great. So
And
when child react like this, that means she's doing something really good for him.
I want to add that I said this in the last talk. This is helpful for all of the practitioners. When you're working with a child who is pretty functional, or depending on whatever it is that you're working on, if you can tell them that you want to make a video and show other children how to do this particular thing, they get very excited because they go from being they go, oh, I'm showing off. Okay, well, let me do this. I say, like, can you show kids who just did SPML how to walk across with the walker or with the parallel bars or walk sideways? Because they don't know how to do it and I need help. And then they become, I said, we're going to have a YouTube channel. As soon as you do that, they get more inspired. And it's up to us to come up with things that's going to inspire them and not just say, okay, now we're going to do 10 of these and 10 of these. And we want to make it fun.
Exactly. Absolutely agree with you. This I absolutely agree. It must be fun for the child. It's not must be like a job for a child or something you put into. It must be always fun. It must be something really interesting to do. Another way, you can't just to work with the child during years. He
Yes.
have to find something inside. And also when he's starting to do something new, like for example, we started to jump with Mark this summer. So he's just excited. He's happy that he can do now jump. And then he's asking, okay, let's practice jumping. That's the point.
So also I want to put a shout out to Chava Shalev, Children's Space, to JKA, Jeremy Krause's Feldenkrais, to Sylvia Shordyke's Neuro Movement. She's in California and sometimes in Germany. To Susie Marks in Chicago, who's a Neuro Movement trainer. Right? Is I saying that right, Amy?
Yeah, I mean, she used to be a trainer. Yeah, for ABM.
So, and Sharon Oliensis in Brooklyn and Verena, what's her last Cruz?
Kurtz.
Kurtz is how you say it.
Kurtz.
That's right, Kurtz in Brooklyn, yeah. A lot of people who are doing different kinds of Feldenkrais and ABM, and Andrea, you have your group and you work with a lot of kids on the spectrum.
Also, yeah. But it's more on the spectrum is more ATAN speciality. It's like
Yeah, some spectrum it's a little bit different, I think. Because we have a
we all
little bit
have
different therapies.
Yeah, we all have our areas where we have some talents.
ABM is very good for children on the spectrum, and Amy is doing a lot of that. I am not, so I just put that out there. And I feel like I can only do what I do well, so. But I wanted people to know that all forms of Feldenkrais I really do admire, and there are different ways of expressing that. So all of those things are, but in terms of SPML, it is a bit specific for right afterwards, and that's where I feel like Amy and I are good at just sort of getting them going, and then we're very happy to collaborate with the practitioners afterwards.
Of course. We'll be happy. It's a pity that my practitioner, she couldn't participate during our discussion. I asked her because you saw her videos also. She's working with great things with Mark. And but maybe next time we'll see. She couldn't do it today. And but I think she's doing some kind of neuro movement method also. It's like neuro movements on her site. So that's somehow related because she what she's doing. Thank you very much for your time, and I will put all the records on my site, and I will send you, because I have just to cut the beginning when we were discussing and so forth, and I will send you the link. And of course you can share whatever you want, where you want. It's open access for all the parents to share anywhere you want.
Thank you.
Thank you.
Yes.
Svetlana.
Thank you very
I
much.
appreciate you so
And
much.
I will put also on my site the 2 documents of Nuzzo. You're
Yes.
giving me permission in English.
Yeah. Also, on the SPML site, it's there, so people just go on it. It's got everybody.
Yeah. Of course, I will put on SPML group also this video.
Yeah.
Generally, the parents, they watch, you see, like with Dr. Nuzzo.
Yeah, and then Svetlana, I can send you this from Anat.
Yes, of course.
And then there's another document as well. It's all about using the 9 essentials just with your child.
Okay.
Any child. So
Okay, just
that will be helpful.
send me by mail with pleasure.
Yeah.
Of course. Any questions? I'm here. You know how to contact me. No problem.
All right, wonderful.
Thank you very much. See you next
Thank
time.
you very much.
Awesome.
Bye-bye,
Have a
colleagues.
great
Bye.
night. Bye-bye.
Thank you.